Welcome to HRS 2011 in San Francisco. I'm Gregory Michaud from Brigham and Women's Hospital in Boston. With me today is Sanjiv Narayan from University of California at San Diego. He presented some very exciting results of the CONFIRM study today in the late-breaking clinical trials. Sanjiv, welcome.
Thanks a lot, Greg.
What does CONFIRM stand for?
It stands for Conventional Ablation for Atrial Fibrillation with or without focal impulse or rotor modulation.
Easier for you to say.
Yes, not that easy.
Why was such a trial necessary?
We've been interested for a long time, along with a lot of other people, on what the mechanisms for human AFib are. We know we've had a lot of success that's continuing to improve with traditional ablation, but ablation generally doesn't identify specific mechanistic targets. Empirically, we know the pulmonary veins are triggers, but we haven't really known what drives AFib after those triggering events.
Please give us an overview of your study.
Okay, so the study was sort of born out of a series of mechanistic investigations I've done at the university and the VA for several years, which looked at the way in which the atrium can respond at different rates in terms of conduction patterns, repolarization patterns, my work in Altanans that you know. And so that led to the fact that we actually ended up seeing localized sources that appeared to be important and very commonly in atrial fibrillation. So having identified these sources, we decided that we would have to prove that they were important in driving atrial fibrillation. And so we designed a trial to use our system, our technology, to identify sources whenever possible. And then prior to any other ablation, we would ablate at those areas and see what happened.
And what were the important results you reported today?
Thanks. So what we actually found were we had 103 patients in the trial total from multiple sites, ourselves, UCLA, Indiana University, and Columbia. And what we showed was that if you look at patients of our population, 2/3 were persistent. They had a variety of comorbidities. We looked at patients who were referred for catheter ablation, and they were they had either conventional ablation or they had this, what we call firm ablation, followed by conventional ablation. We found that in the firm ablation, we were able to rapidly terminate atrial fibrillation at the first site of ablation within 6.5 minutes in 2/3 of the patients. In the remaining, on the whole, we were able to significantly slow the atrial fibrillation by 20 or 30%. In addition to the acute outcome, and that was one of the primary endpoints, we had a long-term outcome, and that was based upon traditional clinic visits, but also the use of intensive continuous monitoring when patients consented, using an implantable loop recorder with an automatic detection algorithm for AFib. And looking at a 2-year endpoint that I presented this morning, we found that after a single procedure, either conventional ablation or firm plus conventional, we found that in the firm plus conventional, 84% of patients were free of AFib or atrial tachycardia, as opposed to 50.5% with conventional ablation.
That's quite a difference. How is your technique different than identifying complex fractionated electrograms or dominant frequency areas?
That's a really great question. What we identified using our novel spatial mapping was sites which showed spatial localization consistent with some very seminal experimental work by Pepe Jalife, Al Waldo, and others that have been shown in those models to drive atrial fibrillation. We were able to find in those areas that targeting those phenomena could slow or terminate AFib. We didn't look just at electrogram characteristics. And if you actually do look at the electrogram characteristics at those sites, and some of this work is still in progress, we don't consistently see CAFE, for instance. We don't consistently see low or high amplitude. We are currently looking at dominant frequency.
Can you conceive of firm mapping being done as a standalone procedure without pulmonary vein isolation, or is it still important to identify and ablate triggers?
That's a great question. Clearly AFib is trigger and substrate based. I would say this is at least a component of substrate, and the study of course looked at both together. So from the study I couldn't extrapolate to doing this without PVI. And so I think at the moment we would definitely consider both together.
Do you think this technique will be applicable to patients with more diseased atria or longer-standing persistent atrial fibrillation?
That's a really great question. So we included persistent, defined by the standard criteria. Because the tools that we used, the commercially available basket catheters that we used, had a physical limit of 60 millimeters. That's the biggest one you can buy. Anyone with a left atrium bigger than that couldn't be included. Therefore, really long-standing persistents who've been in atrial fibrillation for a year or two, whose left atrium is 6.57, we just couldn't get good contacts, and so we couldn't really apply this. Therefore, I can't really comment on how it would work. If you look at the basic mechanistic literature from Halife, Waldman, and others, I think I would optimistically say that these sites are probably present in those patients as well. We'd have to wait and see what the impact of ablation would be.
Well, these results are certainly very promising, and we're excited to see them in publication. Thank you.
Thank you very much, Craig.